Hi everybody, this is Dr. Tamara-Kay Tibby. I'll be lecturing on antibiotics. Antibiotics are life-saving and curative when they're used appropriately. But overuse or misuse has led to the development of many types of antibiotic-resistant bacteria. And this can be deadly. Antibiotic resistance is now a major global public health problem with serious societal costs. Antibiotic-resistant genes are shared between bacteria in the ecosystem. So inappropriate use of antibiotics, even in a single individual, could potentially affect every living creature on Earth. Antibiotics are beneficial in patient care when prescribed and administered correctly for bacterial infections. But the widespread use of antibiotics has permitted common bacteria to develop resistance to drugs. This is an example of MRSA, and it shows what can go wrong when we overprescribe antibiotics and overuse them. To diminish the rate at which resistance is increasing, healthcare providers must be prudent in their use of prescribing antibiotics. Conservative use of antibiotics is indicated to minimize the risk of developing resistance to current antibiotic regimens. So a recent article published in the fall of the JADA, which is Journal of American Dental Association, showed that general and specialty dentists are the third highest prescribers of antibiotics in all outpatient settings in the US, and that's alarming. Dental practitioners should adhere to the following general principles when prescribing antibiotics for the pediatric population. So thinking about wound management, certain factors play a role, like the host risk, their age, systemic illness, malnutrition, the type of wound, example, laceration, puncture. These must all be evaluated when determining the risk of infection and subsequent need for antibiotics. So wound classification. Is the wound clean, potentially contaminated, or contaminated/dirty? Facial lacerations may require topical antibiotic agents rather than systemic. Intraoral lacerations that appear to have been contaminated by extrinsic bacteria, open fractures, and joint injuries have an increased risk of infection and should be covered with antibiotics. So antibiotics requirements. The most effective route of drug administration should be selected. Would it be IV, IM, or oral? And timing is critical to supplement the natural host resistance and bacterial killing. So administer as soon as possible for the best result. So this slide has some areas that are bolded and also starred. So this is important for you to focus on this. You want to monitor the clinical effectiveness of the antibiotics. So the minimal duration of drug therapy is usually between 5 and 10 days. And it's dependent on the specific drug that you're using. And this is key. Antibiotics should be given 5 days beyond the point of substantial improvement or resolution of signs and symptoms. So consider altering or discontinuing antibiotics following determination of either ineffectiveness or cure prior to completion of a full course of therapy. If the infection is not responsive to the initial drug selection, a culture and susceptibility testing of isolates from the infective site may be indicated, and I'll show you that on the next slide, or following slides. So let's first talk about pulpitis, apical periodontitis, draining sinus tract, and localized intraoral swellings. Should you administer antibiotics in this case? So in this situation, the bacteria shown on the slide have gained access to the dentin and then through the dentin to the pulp. And you may have this happen when you have defective restorations as well, or just frank caries. If a child presents with acute symptoms like pulpitis, treatment should be a pulpotomy, pulpectomy, or extraction in situations where you don't have swelling or fever or facial swelling of any kind. So antibiotic therapy is not indicated if the infection is contained within the pulpal tissues or the immediate surrounding tissue, as you see here. Rather, you want to take something more conservative in that situation: pulpotomy, pulpectomy, or extraction, not administering antibiotics. In this case, the child will have no systemic signs of an infection like swelling or fever, and that's why you're not needing to give them an antibiotic, rather rendering treatment instead. So again, considerations for antibiotics, you can look at doing a culture, and this will be done in cases of advanced non-odontogenic bacterial infections such as staph, mucositis, tuberculosis, gonococcal stomatitis, and oral syphilis. If suspected, it's best to refer a patient for culture, a biopsy, or other lab tests for documentation and definitive treatment. So acute facial swelling or dental origin. So if a child presents with facial swelling or facial cellulitis secondary to odontogenic infection, so you know it's from a tooth, they should receive prompt dental attention. In most situations, immediate surgical intervention is appropriate and can help with rapid cure. However, some patients, I'll show you on the next slide, may need to be given antibiotics first. You should consider again their age, ability to obtain adequate anesthesia like local or using general, and the severity of the infection. Medical status and social issues of a child are also important to consider. So in this patient's case, it's a little child that I saw a few years ago. She presented with fever. She had swollen lymph nodes and again, obvious facial asymmetry. As you see, she's swollen on the left side. And this is bordering the rim of the eye, the orbit. So this warrants emergency treatment, such as IV antibiotics and a referral from medical management as well. In this case, the child was sent to the ER. She was giving IV antibiotics and she was admitted for monitoring. So penicillin remains the empirical choice for odontogenic infections. So it's the gold standard. But you may want to consider adjunctive antimicrobial therapy such as metronidazole for those anaerobic bacteria. So dental trauma. In this picture, we see a case where a patient had avulsion of tooth number 9. So systemic antibiotics have been recommended as adjunctive therapy for avulsed permanent incisors with an open or closed apex. So the antibiotic of choice is tetracycline or doxycycline, twice daily for 7 days, and that's the drug of choice. However, we have to consider the child's age because we know that the child's permanent dentition is forming, calcifying at this point in time. So using tetracycline, you may have discoloration of the developing permanent dentition. So rather than using that on a child at that age, you may want to just use penicillin or amoxicillin as an alternative. So the use of topical antibiotics to induce pulpal revascularization in immature non-vitalized traumatic teeth has also been shown to have potential. Luxation injuries in primary dentition you don't require antibiotics for that. But antibiotics may be warranted in cases of concomitant soft tissue injuries, as we discussed before when we talked about wound care. So pediatric periodontal disease, and you'll learn a lot more about this in other lectures during this week. When you have dental plaque-induced gingivitis, you do not require antibiotic therapy. However, this is starred, bolded, going to be very important. Pediatric patients with aggressive perio may require adjunctive antimicrobial therapy in conjunction with localized treatment. So you see some periodontal diseases that are associated with systemic diseases, like you have severe congenital neutropenia, Papillon-Lefebvre syndrome, leukocyte adhesion deficiencies. And these immune system is unable to control the growth of periodontal pathogens. In some cases, treatment may involve antibiotic therapy. You may also want to use antibiotic therapy in conjunction with mechanical debridement in patients with aggressive perio. And in severe refractory cases, extraction may be indicated. And you may also have to culture, do susceptibility testing of isolates on those patients as well before selecting the drug of choice. So viral conditions, this is super important. For conditions of viral origin, you do not use antibiotics. So an example of that would be patients that have primary herpetic gingival stomatitis. That should be more supportive care that's given to these patients. The only time that you would use antibiotics is if you get a secondary bacterial infection with those patients. So salivary gland infections, again, these may warrant antibiotic therapy. You're talking about your parotitis and other types of issues with glands. Another key point is that whenever antibiotics are prescribed to a female patient who's also taking oral contraceptives, you should tell the patient to use additional techniques or barriers during the therapy, antibiotic therapy, and for at least 1 week beyond the last dose. Again, this is bolded, and this is going to be very important for you to know. So antibiotics can render oral contraceptives ineffective. So clinical application. What do you see in this image? You see patient here in the top that has a little, what we call parallus, a little bubble on the gums. And that was because the patient had root canal therapy and actually had a crown on this tooth without root canal therapy, and it ended up abscessing later on. So this is just a paralysis, localized. There's no swelling in that case. And this is more like a fistula. These are kind of like chronic fistulas. If you push on it, you probably would get some more pus out of that. So these, again, as we discussed before, are more localized. They don't involve any extension beyond the localized tissue. So you could just treat these with just extractions. Now, in the bottom case, we see patients here that both exhibit facial asymmetry, hair on the left and on the right. You see there, both have facial asymmetry, and that would warrant having antibiotics administered prior to dental treatment being rendered. And in some situations, it may warrant admission to the hospital, depending on the aggressive nature of it, the child's age, their medical history, and so forth. So penicillin, again, is the gold standard. If the patient's admitted to the hospital, they may get IV ampicillin. Outpatient, they may get amoxicillin or augmentin. This is how you would prescribe it. I believe that you all may get more information on this in other lectures. 20 to 40 milligrams per kilogram per day divided by into 3 doses is what you prescribe. And amoxicillin comes in 125 milligrams per 5 cc's and 250 milligrams per 5 cc's. Now, some oral surgeons prefer the use of clindamycin. It's a broad spectrum antibiotic, or they may do a culture, as we discussed before, so you get the right antibiotic depending on what you culture out of that infection. And again, patients who have allergies to amoxicillin, you may want to use clindamycin as well. So why would you hospitalize a patient? And I showed you the slide of that young girl. So if you have a rapid onset and extensive facial cellulitis involving or encroaching on the eye, or you have airway issues like trismus where they have a problem opening or swallowing hurts or dysphagia, that may be a cause for concern, and those patients may be admitted. Also, if you have issues like social factors, like a child whose parents may not be compliant with care and you're concerned about them following directions, it may be a cause to hospitalize those patients. Any patient that's immunocompromised, if the patient's not eating or drinking, they may require medical attention to rehydrate and so forth. So I'm going to show you just a couple patient cases. I had a really sweet young man that presented with a facial cellulitis. We gave him antibiotic and then brought him back for the extraction. Even after having the antibiotic course, he still had quite a bit of significant swelling around the tooth. It's more localized than it was before, but it's definitely still present. This patient was already, I'm using laughing gas here, and they were already numbed. And we started the procedure, so you see a little bit of bleeding back here as well. So there's a little bit of pus, a little bit of swelling on either side of the tooth. And what tooth is that? So this one back here is number 19. What baby tooth is that? You said tooth K, you're correct. And this child, what age do you think this child is? So they have their 24 and 25 present, about age 7, yes. So we numbed the patient, giving them local, a block, reflected tissue, and we got some pus and also just, a little bit of drainage here. We drain that out and then we remove the tooth on the same day. This is called a molt mouth prop. It just kind of ensures that the child remains open. So this is a case that didn't go so well. It was a child who had a history of avulsion of tooth number 8. We followed it with images. I don't have the x-rays, I apologize, but over time she developed what we see here, which is a little bit of swelling into the depth of the vestibule, a parallus associated with tooth number 8. And you can tell that because of the difference in the depth of the vestibule here. See how it's concave and here it's convex. It's a little bit of swelling. So unfortunately, we had no other option but to remove her tooth. And we were able to do a flipper for her. And this was the final result. So thank you all for tuning in. I hope you enjoyed this. If you have any questions, you're welcome to send me an email, tktibby@gmail.com. Thank you.